morning everyone. At the onset, I would like to thank Dr. Srinivas Kishore, who has been a mentor to me and at the same time has given me this opportunity to interact with such a learned audience. I have nothing to disclose. First of all, I would like to reiterate this definition of sleep apnea. I am sure most of you have read this definition multiple times in the past, but I would like you to dissect it word by word here. In the presence of an anatomically compromised collapsible airway, the sleep-induced loss of compensatory tonic input to the upper airway dilator motor neurons leads to collapse of the pharyngeal air. In the further talk, I'll be dissecting out each and every word of this definition, and that's what this whole 13-minute talk will be about. So these are two landmark papers which have helped me make my talk. And the first paper is by Dr. Jeremy Dempsey, the second one is by Dr. Danny Eckert, and I would urge you all to have a look at these two papers. So the basis of pathophysiology lies on 4 pillars. The first pillar is anatomy, second one being the pharyngeal dilator muscle response, third is high loop gain, and fourth is a low arousal threshold. So the first pillar, anatomy, which is arguably the most important pillar in the causation of obstructive sleep apnea. So the first fundamental of anatomy is a classical Stirling resistor model, which says that the whole passage, the whole airway, is a collapsible segment lying between two rigid segments. The collapsible segment here is the oropharynx, which lies between the rigid segment number 1, which is nose, and the rigid segment number 2, which is trachea. The pharyngeal critical pressure is the pressure at which this collapsible segment collapses, and the same pressure when given from inside will help this segment to open. So a high P crit or a high critical pharyngeal pressure means that the airway is highly collapsible. Now, why this airway is highly collapsible? It is because all the pharyngeal dilator muscles are suspended by this poor bone, I must say, the hyoid bone, which has no rigid support of its own. So the flow, the airflow actually depends on the gradient of this pressure upstream and the pressure in the middle segment, which is the P crit. The difference between this pressure, the pressure at the nasal cavity and the pressure at the oropharynx, is what determines the airflow through the air passage. And to increase this airflow, we can either increase the upper segment pressure, which is by a CPAP therapy, or we can decrease the P crit by using a surgical method or by causing a parapharyngeal fat loss, which is what we prescribe to many patients in form of weight reduction therapies. Now the second fundamental of anatomy, the skeletal framework is as important as the soft tissue framework. Here I would like to use this paper by Dr. Srinivas Kishore, Dr. Vikas Agarwal and Dr. Vijay Krishnan, which talks about this sand and jar concept, which says that skeletal anatomy is like a jar, and the bone forms this outline of the jar. The sand inside is the soft tissue anatomy, and the straw that you see is the airway. Now, a compromise in either the jar or the sand inside will cause the airway to become more and more collapsible. Third fundamental of anatomy, which is the Poisson's law, which we read it back in our physics classes, which says flow is directly proportional to the 4th power of radius in case of a fluid flowing through a tube. So the flow of the fluid is directly dependent on the cross-sectional area of the passage. Now here is the importance of tackling static obstructions. Even a mild obstruction like a nasal polyp or an adenoid hypertrophy will cause a substantial decrease in the airflow. Now anatomy fundamental number 4, which is the Bernoulli's theorem, which says that a collapsible part of the tube, when narrowed, will collapse further. Imagine yourself sucking a fluid through a thin straw. Now imagine that you are sucking it too hard. It will collapse further. It will pinch further. And here there are multiple concepts like increased visceral fat, Airway edema in case of smokers, presence of nasal obstructions, nasal polyps will cause a person to suck in air harder, which will cause the oropharynx to collapse further. So after talking about the anatomy, I would like you to know about impaired muscle responsiveness, which is seen in many sleep apnea patients. The first fundamental of physiology is the central regulation of breathing. This is what we see in an awake state, that dorsal respiratory group is responsible for our inspiratory action of breathing, and the ventral respiratory group is responsible for expiration. However, when we sleep, the dorsal respiratory group or the inspiratory neurons are solely dependent on the chemoreceptors, which is the increased CO2 levels in the body or the hypoxia to drive the inspiration. So our body is solely dependent on increased CO2 levels at night to drive this pharyngeal dilator muscle function or the inspiratory action. Fundamental number 2, an increased negative intrapharyngeal pressure along with hypercapnia will lead to a genioglossus muscle activation, which is what the central muscle response is. However, in many of the sleep apnea patients, this muscle activation is impaired. This is a beautiful paper by Dr. Sushil Patil et al., which says that neuromuscular responses is what is standing between a poor anatomy and sleep apnea. In case a patient has sleep apnea, only a compensatory neuromuscular response can cause the patient to escape sleep apnea. However, neuromuscular responses do decrease as we age, and that is why snoring prevalence increases as a person ages. Now I'll be talking briefly about these newer concepts called loop gain and arousal threshold. There are subsequent talks which talk these concepts in detail, and I'm not supposed to go in detail here. Loop gain is where the central response system, the central inspiration or the control of breathing, oscillates between being lazy and being overactive. So in case of a sleep apnea patient having a high loop gain, he will be dependent on increased CO2 levels much more than the normal CO2 accepted levels. And in case of this hypercapnia, he will land up in hyperventilation mode, which will cause a CO2 washout, and this will cause hypocapnia. Now the patient is dependent on hypercapnia for ventilation. So hypocapnia will cause a lack of respiratory drive and will further cause apnea. The fourth concept, low arousal threshold. Now this is simply that the patient doesn't go in deeper planes of sleep, which causes an inability of the airway to recruit genioglossus negative pressure reflex, which would have come if the patient had landed in deeper planes of sleep. Now this is where a patient has an arousal premature before landing in deeper planes of sleep and disturbs the sleep, causing sleep fragmentation. Now why are we worried about sleep apnea at all? What are the systemic effects of sleep apnea? So sleep apnea will cause intrathoracic pressure fluctuations at night, number 1. Number 2, it causes hypercapnia. Number 3, it causes sleep fragmentation. All these 3 factors will cause an increase in the circulating inflammatory marker load in body. And this will also cause an increase in the sympathetic drive. These factors will lead to the metabolic manifestations of sleep apnea that we see, which is hypertension, coronary artery disease, impaired glucose tolerance, cerebrovascular disease, and atherosclerosis. So the take-home message that I wanted to drive home here is that cyclical OSA requires a poor anatomy as a prerequisite. Poor anatomy means a high critical pharyngeal pressure, a high peak rate, which means that the oropharynx is highly collapsible. However, though the patient has high peak rate, it doesn't mean that he will land up in a sleep apnea state. The neuromuscular compensatory mechanisms are always there to rescue the patients. However, failure of these rescue mechanisms, these neuromuscular compensatory mechanisms, will land the patient in sleep apnea. And that is why, as a patient ages, the sleep apnea prevalence becomes more and more. High loop gain and low arousal threshold will complicate the picture in 1/3 of the sleep patients. And that is why it is important to understand these concepts. And there are further talks planned for explaining these topics to you. So I will take your leave here, and any questions from the audience is welcome.
Thank you, Anupam. Wonderful. And you finished on time. Any questions? He's got time. Okay. If there are any questions, we'll take that. Right. So thank you very much, Anupam.